Hi, I'm Professor Mehmet Engin. Today, I'm going to talk about research on breast thermogram classification. This seminar is based on the related review papers. Now, the outline of this seminar. Firstly, introduction, standard screening methods, breast thermal imaging modality, that including the subtitles, potential of breast thermal imaging, breast thermography, breast thermal dataset, and breast thermal features. Research and classification. Future works, including the subtitles, representative dataset, automatic segmentation and augmentation, good kernel, mobile lightweight, and finally conclusions. Now, this is introduction. Global cancer data show that breast cancer is the second most lethal form of cancer worldwide after lung cancer. A cohort study showed that 70% of breast cancer cases are detected when the tumor size was 30 millimeter. Breast cancer usually becomes detectable during screening when the tumor is at least 20 millimeter in size. Therefore, enabling early detection of breast cancer is critical to facilitate early treatment. Early treatment may be beneficial following identification through the screening examination, such as clinical breast examination, namely CBE, and breast self-examination, namely BSE. Clinical breast examination is a regular medical examination performed by healthcare professionals to detect breast lesions, whereas breast self-examination is conducted by an individual to observe physical changes and appearance of breast. The practice of breast self-examination empowers women to take responsibility for their health. Consequently, BSE is recommended by the World Health Organization for raising awareness among women at risk. Screening methods produce medical images of breast. The interpretation of these images is normally performed by human experts, such as radiologists and doctors. Research shows that the low diagnostic accuracy of thermograms is attributed to weak technical ability and expertise in interpreting such images. The emergence of various diseases and limited human labor has motivated researchers and medical personnel to use computer-assisted technology to facilitate breast thermography-based diagnosis and thus minimize errors. Therefore, a computer system that can automatically classify thermograms into normal and abnormal categories is required. Considering these requirements, research towards finding computer-based solutions to classify medical images has been continuously growing. Many computer-assisted methods of diagnosis have been developed to assist doctors in interpreting the medical images. During the last decades, significant effort has focused on the development of deep learning models, such as machine learning models. Because DL, or deep learning models, are publicly available, they can be applied easily using pre-trained networks. In breast cancer detection, many studies are based on deep learning using mammograms, histology images, tomosynthesis, and ultrasound images have shown satisfactory accuracies. In contrast, relatively few studies have contributed to non-invasive thermal of breast using the deep learning networks or DNN technique. Considering the current limited resources, the work on this problem is still in its early stages. Hence, significant effort is required to develop reliable non-invasive computer-assisted technology to enable early detection of breast cancer. These necessities of study of relevant previous, current, and necessary feature research on thermal imaging and deep learning for breast cancer detection should be considered of paramount importance. Potential research could be directed and focused on the substantial outstanding issues identified in this study. Now, standard screening methods. Breast cancer risk assessment is critical for identifying women who may benefit from more intensive breast cancer surveillance. Prior to surveillance, one must undergo a screening test. Currently, the gold standard screening method for early breast cancer detection is mammography and X-ray examination, where the breast is placed on the stand and pressed by the disc to spread the breast tissue evenly and capture characteristics of microcalcification. Similar to all X-ray imaging, mammography involves the use of the doses of ionizing radiation to create images. Repeated mammography screening may increase breast cancer risk due to exposure to ionizing radiation. Another screening technique that uses a small amount of radioactivity is positron emission tomography, namely PET. Radioactive materials termed radiotracer or radiopharmaceuticals are injected into the body, such that a part of the body with greater absorption of radioactive tracers may indicate disease. PET combined with computer tomography CT allows the retrieval of information about the size, shape, and location of tumor. All the examination using PET and CT is non-invasive, but the injection procedure is invasive, and the use of radioactive materials can be harmful to patients. A non-invasive ultrasound breast screening methods uses high-frequency sound waves that bounce off the breast tissue and are collected as an echo to produce an image. This technique has limitation in identifying classification of women aged above 40 years. When performing ultrasound, specific and improved anatomical knowledge is required as a formal educational program. Early detection of breast cancer can also be achieved using magnetic resonance imaging, MRI, PET, CT, and ultrasound. Using radio waves and magnetic fields, breast images are obtained when diagnostic mammography cannot identify tumor or other possible growth of lump in mammograms. MRI scanning or screening is a well-adapted or studying soft tissues. However, in some patients, the procedures can cause claustrophobia and the procedure involves high expenses. Recently, a screening method called thermography was promoted as a risk-free, low-cost, non-contact imaging technique. Thermography is a non-invasive breast cancer screening approach that uses thermal camera to capture breast images. It allows early detection using thermal anomaly information of breast asymmetry. Breast cancer can produce variations in the mammary thermal pattern prior to clinical and mammographic changes, namely visible breast tissue on mammograms. Thermography can detect breast cancer up to 10 years earlier than mammography. However, thermography has a high false positive rate depending on classification technique used for interpretation. Consequently, reliable classification method for breast cancer is necessary. Now, breast thermal imaging modality. Infrared waves are within the wavelength range of the light and microwaves. All objects can emit infrared radiation as a function of temperature of that object. Heating an object increases the amount of infrared radiation released and causes it to propagate in shorter waves. Infrared radiation generally covers wavelengths from 0.75 to 1000 micrometer, whereas the wavelengths emitted by the human body during the diagnostic measurements are at narrow band wavelengths 8 to 12 micrometer, which are termed the long-wave infrared. In medical infrared imaging, this range is known as thermal infrared or TIR. Within this range, infrared emission usually occurs at heat or thermal radiation, the measurement of which is termed thermography. The image produced by TIR imaging is called a thermogram. This infrared wave cannot be visually observed because it lies outside the wavelengths of visible light, but can be captured using thermal camera. Now, potential of breast thermogram modality. In general, thermography has two advantages. First, it is thermographic nature, which is non-invasive and enables visualization and quantification, facilitates risk-free detection of breast cancer. Second one, thermography facilitates real-time imaging, allowing data storage and computer, which can be later used for data processing. Despite these advantages, thermography it is not considered as a replacement for mammography. Mammography remains the gold standard screening techniques and offers an effective means for early breast cancer detection. However, certain factors can affect the diagnostic accuracy of mammography. First one, mammography primarily depends on structural distinction and anatomical variation of the tumor from surrounding breast tissue. Second one, mammography sensitivity is higher for older women than for younger women. Comprehensive research concerning the medical imaging modalities for diagnostic breast cancer suggests that thermography is a superior imaging modality for dense breast tissues and their early detection. This finding is supported by previous research, which indicated that thermography could be corrected from 8 to 10 years before mammography can detect as mass. Furthermore, mammography has difficulties in reading a large, dense, and fibrocystic breasts. As discussed in previous studies, to reliably detect tumor using X-ray, the density of the lamp should be more than that of the surrounding tissue. Consequently, mammography is mainly applicable to a woman aged above 45 years. As reported previously, the average size of the tumor undetected by thermal imaging and mammography is 1.28 and 1.66 centimeter respectively, indicating that thermography can facilitate early tumor detection. Nevertheless, further studies didn't recommend the use of digital infrared thermal imaging or DITI for a woman with history of surgery or core biopsy, despite the fact that it is non-invasive and painless. This is due to low sensitivity of DT hindering its recommendation as primary evaluation or routine basic screening for breast cancer. Compare the accuracy of thermography and mammography in detecting breast cancer, verifying that the accuracy of mammography is higher than the thermography. In conclusions, at that time, thermography couldn't replace mammography as an early breast cancer detection method. However, the use of thermography as a companion to mammography is highly recommended to obtain maximum test results. Now, breast thermography. Changes in temperature distribution are symptom of abnormality in body tissues. Thermal distribution of cancerous breast and tumor volume friction in the heterogeneous zone influences the breast surface temperature. However, given the limitation of the human visual system, such as temperature differences are difficult to detect. Therefore, a system that can detect changes in temperature distribution is required. In 1957, reported the thermography is a new tool for investigating breast lesions. Infrared photons represent only a narrow band of electromagnetic spectrum, but the information contained within these images is fundamentally associated with functional status and movement in the body. The following several decades after development, a new system for acquiring surface thermal patterns of the breast and image interpretation was developed, and termed thermal texture mapping. Thermal texture maps were introduced in 2004 to solve this inverse problem at the heat transfer equation by locating inner abnormal heat sources and their metabolic status. Complementary non-invasive tool for thermograms acquisition was then introduced. In these methods, the IR or infrared thermographic devices is placed by approximately 1 to 1.2 meter away from the relaxed sleep patient. At this distance, the minimum measurable spot size is 0.5 centimeter, which allows the measurement of cancer tumor size larger than 0.5 centimeters. Two types of protocol may be employed in capturing the image, static and dynamic protocols. The static protocols involves a single image capture after 10 or 15 minutes of thermal stabilization during rest, whereas dynamic protocols involves a series of thermogram captured every 15 seconds during 5 minutes. It is important to note that menstruation cycle must be considered when conducting thermography. Patients and 20 days of menstruation cycle has an unstable body temperature resulting in false positive interpretation of her breast thermogram. Hence, thermography is recommended to be performed within 50 and 12th or and the 21st day of menstruation to avoid false interpretation. Now, breast thermal data set. Several studies on the breast thermal acquisition have been conducted during the last decades. As shown on Table 1, the first dataset was selected from images taken in 1984 by Dr. Dominique Fries and her team using the first generation thermographic camera, ThermoVision. Unlike the large number of mammograms that are stored in public digital database, breast thermograms are stored mainly in private database. Current relatively few public breast thermogram database available, such as ProAnc. Other online datasets include those used previously from Ann Arbor Thermography, the Thermal Imaging Lab in San Francisco Bay Area, American College of Clinical Thermology, Thermography of Iowa, and Sun State Thermal Imaging Center in Australia. It is suggested that more studies of breast thermogram acquisition with universal standards should be undertaken in the future to support specialists and researchers in their educational and research activities. Moreover, data sets are the primary concern in the training process in deep neural networks. Now, breast thermal features. A feature is any distinctive aspects or characteristics that is used to solve a computational task related to a certain application. Each breast has particular thermographic characteristics or patterns that don't change over time. Slight temperature variation in the breast indicates new development in the breast and warrant further examination. This is based on assumption that breast temperature should be symmetrical. Thus, if one breast has cancerous cells, then the two breast thermograms will deviate from each other. In general, the highest average mean temperature deviation of patients with breast cancer and benign is 0.5 degrees of Celsius approximately, and with the healthy one is approximately 0.85 degrees of Celsius. The symmetry of breast thermograms is described by the image features, which can be used as a parameter to classify the thermograms of patients with and without cancer. Regarding deep learning models, such features will be used as inputs for the classification algorithm. Thus, it is important to identify image features that uniquely describe the symmetry patterns of breast thermal distribution. It is proposed a statistical method to identify parameters that best distinguish healthy, benign, and malignant groups of patients. First, the correlation coefficient of the variable, mean, standard deviation, median, and mode of the temperatures was calculated and tested for significance. The results show that the mean, median, and mode have a low correlation coefficient among the healthy, benign, and carcinoma cases, but a high correlation between breast in individual groups. However, the standard deviation shows a low correlation between the breast of each case. Second, using distinctive statistics, histograms of each breast were obtained. The histograms of the carcinoma case show the significantly different squamous and mean temperatures compared with those of normal and abnormal breast. Figure 1 compares the histograms of healthy and cancerous thermograms to illustrate their different temperature distribution. Figure A shows an image of healthy patient indicating no significant differences in the histograms of both breasts. However, figure B shows an image of patients with cancer on the left side of the breast. The temperature distribution is asymmetrical and has a different mean temperatures compared with those of normal side. An investigation to determine the breast thermogram signatures was further conducted, and first and second order of statistical parameters were analyzed. The investigation confirmed that among the analyzed first order parameters, only mean and squamous were promising for successful classification of breast thermograms, but they were not effective for separating breast thermograms with and without tumor when used as input for neural networks. On the other hand, second-order approach, namely co-occurrence metrics, provided better results because it is difference variation and variance allows the separation of almost all healthy and malignant tumor cases. A study applied both histogram statistical and gray level co-occurrence metrics, or GLCM, for the identification of textural features of breast thermograms. Features of segmented breast thermograms were extracted using the first-order statistics of entropy, kurtosis, mean, squamous, standard deviation, and variance. On the other hand, gray-level co-occurrence matrix entities of contrast, correlation, energy, and homogeneity were used to describe the texture features. The mean value was the most significant value of the first-order statistics to separate cancerous and healthy thermograms. In texture-related, GLCM, contrast, homogeneity, and energy were justified as the most distinctive values distinguishing healthy and cancerous thermograms. Now, research on the breast thermogram classification. A cohort study in 22 initiated works of the early breast cancer detection using neural networks. For backpropagation neural networks were developed to examine the accuracy of detection based on breast thermograms. These examinations classified the breast cases into normal, benign, and malignant groups. Although its accuracy rate was poor, this study confirmed the potential of using breast thermograms with neural networks to detect breast cancer at early stages. Subsequently, more approaches were developed. And then, an advanced integrated techniques for artificial neural networks and biostatistics was conducted. It is implemented artificial neural networks, or ANN, of radial basis function networks, RBFN, The prediction in identifying breast cancer in healthy and cancerous classes results approximately 80.9% for accuracy rate with 100% sensitivity and 70.6% specificity. Through these kinds of studies, objective of improving the maximum accuracy to 100% has been targeted. The optimization of neural network approaches using deep neural network approach has motivated the implementation of DNN or deep neural network model in classifying the breast thermal medical imaging. Now, future works. Based on this review of literature, it is affirmed that deep neural network or deep learning implementation in medical image classification results in higher accuracy than other neural networks methods. When detecting breast cancer using DN or deep learning, two critical points must be addressed. How to detect an early stages and use of high accuracy rate. A deep learning algorithms requires a large data set to ensure 100% accuracy validation. Thus, to enable effectiveness deep learning in classifying breast thermograms, availability of representative data set is essential. To enable early detection, breast screening examination can be conducted by breast self-examination method. Hence, a deep learning algorithm should be lightweight to allow the installation of application and portable device capable of supporting self-screening. Breast thermograms with region of interest of breast as an input should support less computation for lightweight model. To facilitate these requirements, we recommend that future efforts should be taken into account the production of the representative dataset, assembling segmentation and augmentation algorithms, assigning a good kernel, and building a lightweight CNN model or convolutional neural network. Conclusions. Early detection of breast cancer remains the cornerstone of breast cancer control. Breast self-examination is recommended by the World Health Organization to raise women awareness of breast cancer risks. Thermography has been proposed as an early detection screening method, and we believe that it provides a promising development towards a self-screening method that can detect breast cancer at an early stage. An overview of the breast thermogram's potential indicates that the early symptoms of breast cancer can be observed by identifying the asymmetrical thermal distribution between the breasts. The asymmetrical thermal distribution on breast thermograms can be evaluated using computer-assisted technology. The use of this technology can minimize errors. This study shows that the current neural network models have led to an increase in accuracy of the breast cancer thermogram classification, particularly in distinguishing between healthy and cancerous cases. Nevertheless, the performance of the neural networks model must be improved. Future research needs to work towards improved classification of breast thermograms. This will require providing representative data sets, preparing good region of interest or segmentation model, assigning good kernel for learning algorithms, implementing lightweight CNN models. Achievement of these objectives will shorten the time involved in convolutional computation and increase accuracy rates. A risk-free screening method using thermography could be proposed for self-breast screening method at an early stage without requiring physical involvement. Thank you. See you again. Bye.